Hip dysplasias and transient synovitis. What are hip dysplasias? As you know, that initially they were actually called as congenital developmental dysplasia or congenital hip dysplasia, which was also called as CHD, but now it is called as developmental hip dysplasias, that is the DDH. Why it's called a developmental dysplasia of the hip? Because if you see, this is a normal pelvis and hip joint of a newborn. If you can appreciate it over here, both the head of the femur are very much in the acetabulum and they are well maintained into the acetabulum. Initially it was called as congenital hip dysplasia because it was presumed that actually the problem is in the dysplastic acetabulum. The acetabulum becomes dysplastic, as a result the hip goes out, or the head of the femur actually comes out of the said socket. But the problem, this was later diagnosed that it's not purely congenital. Sometimes there is always some form of a dysplasia there, but the muscles which are actually acting on the proximal head of the femur and the neck sometimes actually cause the head to be displaced forward and come out of the acetabulum, mimicking some form of a dysplasia. And as the child starts to get beer, as the child starts to walk, as the child starts to crawl, the dynamics of the hip change, and as the muscle becomes more and more stronger, actually the pull of the muscle increases, leading to increased acetabular problems and leading to increased dysplasia. Now there are certain terms which is called as acetabular dysplasia or dysplastic acetabulum. Now there is always some form of dysplasia is there. It's not purely a congruous hip, and when the child starts to walk and as child becomes around 3 or 4 years of age, the things have become so problematic that the hip actually comes out of the acetabulum and proximally migrates. Now if you see it over here, there is some form of a dysplasia of the acetabulum which is usually present at birth, but as the child starts to walk, as the child starts to get beer, this dysplastic acetabulum, which is unable to contain the head of the femur, as a result the muscle acting on it pushes the head out and above, leading to increased dysplasia. And eventually when you see an x-ray of a child of, let's say, 3 or 4 years of the dysplastic acetabulum which is left untreated, you will be amazed to see that the femoral head would be right over here around at the level of iliac wing. Sometimes they migrate so high up, and there is a definitive tonus grading for that how much of the head has actually migrated out and above at the level of the iliac wing. So it is important to understand that initially it was called as CDH or congenital dysplasia of hip, but now it is called as developmental dysplasia and associated with certain packaging disorders, especially the CMT, metatarsus adductus, and other problems such as increased femoral anteversion and increased tibial internal torsion. Now there is a different way of classifying the dysplasia of hip. One way of classification is as presents. For example, this is reduced and stable but dysplastic hip. Now this was a classical congenital dysplasia of the hip, in which the head of the femur is well aligned and is actually present inside the acetabular cup, but the acetabular cup appears to be dysplastic. That means that it is either there is an increased acetabular angle, or which may be leading to acetabular index, which is actually leading to more dysplasia, or there is actually decreased central edge angle of the Weisberg, which is also protects the for lateral translation of the head of the femur. So if there would be dysplastic or there would be deficient acetabulum at any level, and most commonly actually it's anterolateral deficiency of the acetabulum, as a result the head migrates laterally and upward. The next form is reduced but dislocatable. Now this is called as unstable hip. For example, when a child is born and there is some form of acetabular dysplasia, usually the ossification of femoral head is actually not there, and clinically the only way to look for is to go for Barlow and Ottoloni test. And when you do the Barlow test, the hip comes out with a clunk, that is, it's dislocatable. But when you do the autonomy test, it actually reduces back in. Therefore, there's an unstable hip which can get dislocated, but it actually also reducible. So one way of classifying is reduced and stable but dysplastic acetabular hip. Then it's a reduced but dislocatable hip, which is a form of unstable hip. The third way of classifying is dislocated but reduced. When you see the Barlow is actually already positive and the patient, usually the hip is already outside the acetabular socket. But when you do the autonomy, it actually comes back in. But it's so unstable that it goes back out quickly. Therefore, this is a kind of a hip in which the head is already dislocated and it's lying outside, but it's still reducible with a certain maneuver. Then comes the last part, or the one way of classifying is the dislocated and irreducible. Now, dislocated and irreducible form of hip means it could be a teratological form of a hip, which is hip dysplasias which develop in utero, that is when the fetus, the child is in the mother's womb. Those dysplasias can be more significant and they are more lethal, and usually they are as over the period of time the contractures of the hip have developed so much that usually they are not reducible, and these are classically called as teratologic type of a hip, which are dislocated and there is actually the head of the femur is irreducible. Now, what is the pathophysiology? What exactly causes the developmental dysplasia of hip? There are multiple theories. There is no exact proven cause, but there is certain association with certain diseases as well. The first and foremost is actually the ligamentous laxity. This is often inherited, although this is not the isolated cause. Usually, the ligaments of the child are lax, and when actually they're lying in the position, this usually have an associated. This may lead to certain subluxation or dislocation of the joint. Now remember, as I told you, the spectrum of disease could be simply dysplastic acetabulum with a reduced head. This could be dysplastic acetabulum with slightly subluxed head, or this could be a frank dislocation of the head, which is even irreducible as well, leading to a teratological type of hip. So this is a whole spectrum of a disease. All this can be a presentation of developmental dysplasia hip, and one of the pathophysiological causes is always the ligamentous laxity. The next most commonly associated problem is actually, especially if it's the first child, if it's a female child and is having a breech delivery, usually especially the foot-length breech. Now, in this kind of a problem, one hip is actually lying on the iliac spine of the mother. As a result, this is usually leads to increase. The posture of the baby is such that this leads to increase problems and eventually results in form of a dysplasia. Now, breech position usually results is one of the very most common risk factors, and especially if a child is born who happens to be female and the first female child and there is a breech delivery as well, then one must do the autonomy and Barlow to rule out whether he or she child is having a developmental dysplasia of hip or not. Then postnatal positioning, usually this is all related to actually in utero positioning, and sometimes it's postnatal as well, in which the hips are swaddled in extension. In certain cultures, there is actually a tendency of child to actually tie them at their back, behind their back, and when the mothers go to work, they put the babies in a certain position in which the hips are actually flexed, externally rotated and abducted. In this, the hips are swaddled in extension. This actually leads to increased dysplasia, because remember, it's not purely congenital. As the child grows and the muscle power develops, that is associated with the this developmental of pathology also develops along with the age as the age progresses. Then there may be, the problem may be actually the primary acetabular dysplasia. The acetabulum may be so dysplastic that it cannot actually contain head, and as a result, when the child flexes the hip due to the dysplastic acetabulum, the head subluxes or dislocates out. This may be one of the main cause leading to developmental dysplasia of hip. But always remember, first child, female, and a breech delivery. You must do autonomy and Barlow. And remember, it's not the X-rays which is the diagnosis, it's always the clinical suspicion, your clinical judgment, and your clinical test which actually diagnose developmental dysplasia of hip. Now, there's usually a one-day child, how would that child give you any history? So if usually the children they have certain problems, there's something peculiar about their thighs, and usually within the first week the parents come to you and say that, look, there's something wrong with his or her thighs. And when you see it, you clearly see this problem is actually there are asymmetrical thighs. And if you see, this is a classically female child, if you see there are only one crease over here and there are two creases, so probably either this side is something wrong or this is something wrong. But if you see the abduction over there is quite much, but over on the left side there's also limited abduction as well. So that should also raise the suspicion that if there is limited abduction, there is asymmetrical skin folds of the thigh, then there is something wrong on the left side. And then instead of going for the x-rays, because usually the femoral head ossifies at 3 to 4 months of age, the problem is such that once it's there is actually before 3 to 4 months, if you get an x-ray, you will not see any femoral head over there. So it will be difficult to actually determine whether it's dislocated, it's subluxed, or is actually there is a problem with it or not, or it's actually confined into the acetabulum in a normal fashion. Therefore, what you need to understand that there are certain other clinical tests which you need to do to actually exactly rule out the DDH. And those clinical tests actually mean the diagnosis can be made by Barlow test and Ottoloni test. And then there is also a Gleason test. What is a Barlow test? Barlow test is that you basically, the child is lying in front of you, supine, you adduct the hip with the knees in contact, and then you push the femoral head backward. As you push it backward, if there is deficiency, the hip will dislocate and you will feel the clunk. Now there is a difference between a click and a clunk. Now click is something you hear. Click could be anything. When you're testing something, you just hear a sort of a click. But a clunk is something when the femoral head dislocates out, you actually feel the thud on your hands. That is called as clunk. So you feel the clunk and you hear the click. So remember this. So when you're doing the Barlow, there will not be a clicking sound. There will be a clunking sound over there. And you will feel the thud that something has actually gone out or dislocated out of the hip joint. Therefore, once you do that, becomes the Barlow is positive. And when the Barlow is positive, this means the hip is dislocatable. And if it's negative, either the hip is there is no dysplasia, or this means the hip is already dislocated, and then you will have to go for Ottoloni to check whether it is reducible or not. The next test comes is Ottoloni. Once you have adducted the thighs and with the knees in ground and you push it by the hip backward, this is doing the Barlow. And if you feel the clunk, then you have to do the Ottoloni, that you abduct the thighs with your middle finger or with your index finger, you push the head back towards the acetabulum. Therefore, you abduct the thighs and you push it back on the left side or the right side. Or if it's bilateral, then you have to do it one by one. First the right side or the left side, and then the next other side. And once you do that, so you are clear cut, you have a clear cut idea whether it is a bilateral, is it on one side, or where exactly it's going. And then once you reduce the head back and it reduces with a clunk, this means Ottoloni is positive. Now remember, these tests will not be positive after, let's see, 4 or 5 months, 3 or 4 months of age. So if a child comes to you who happens to be a neglected DDH, let's say of 1 year of age, and there are a lot of issues with it, there is LLD, the limb length discrepancy, the child is having a limp, child is having a tilted and oblique pelvis, and the problems are there. And then there are asymmetrical skin fold in the thigh as well. Then you don't go for these tests, because by that time the femoral head is ossified, and we can go for straight away the x-rays of the pelvis, because by that time either the contractions would have developed, and these tests are only possible because once the hip is either dislocatable or reducible. Because once the hip becomes irreducible and becomes completely dislocated and irreducible, both the Barlow and Ortolani become negative. Now the next test is actually for a child who presents before 3 to 4 months of age and is Barlow and Ortolani is positive. Then just to get an idea whether the problem is at the hip joint, is at the femur level, or at the lower levels, because sometimes the only sign could be the asymmetry of the limb lengths. One limb may appear slightly shorter as compared to the other side. So when that happens, you have to understand that you have to judge clinically whether this shortening is due to the problem at the tibia, problem at the femur, and if it's at the femur, is it below the level of trochanter or above the level of trochanters. So a simple test is actually the Galeazzi. If you see it over here, from the front, if you are looking at the tibia, both appear abnormal. And if you will look at this patient from the side, you will see the femur will be parallel. The bones which are parallel, that is where the pathology is. If the tibia is parallel, the pathology is at the tibia. But if the femur are parallel, the pathology is at the femur. Then next is you have to look for is whether it's supratrochanteric and infratrochanteric, but that is usually not required in the case of a DDH. In DDH, if you use the Galeazzi, the parallel would come out to be the femur. Femoral shafts would be parallel to each other, and you would immediately see, okay, if a child who is, let's say, 1 month old, 7 days, or 10 days old, there are asymmetrical skin folds, his or her Barlow and Ortolani test are positive, then there is a Galeazzi test is positive for this parallelism seen at the femoral shafts. Then most likely the problem is at the hip joint, and with most common cause at this stage is actually the developmental dysplasia of hip. Now, how to do the Barlow test. If you see it over here, this is also explaining the Barlow test. The best way is to make the child comfortable and lie it supine. Usually the mother and parents should be around, because the child can start crying, and then it would be difficult to perform the test. You simply ask them to remove the clothes or the pants or trousers, whatever the child is wearing. There is no need to actually remove the pampers, but once you remove, you bring both legs from abduction position into adduction. And once you bring that into adduction, you push it from your knees backward at the hip joint, as if you are trying to actually dislocate the head of the femur out posteriorly. And if it goes out with a clunk, this means the Barlow test is positive. And usually the most common cause of the Barlow test in a first child, female, with a history of breech presentation, the diagnosis which should just click your mind should be the developmental dysplasia of hip. And that is what it is showing. If they have done this adduction, and then with the knee they're actually pushing it backwards. Once this happens, if there is a dysplasia of hip, the femoral head will come out or dislocate with a clunk, and then that would make the Barlow test positive. Next is how to actually perform an Ortolani test. Now from adduction we have pushed backward, and then we have dislocated the hip. Now from that position, with the knees were tight together, we abduct the thighs. That is, we make it them. Once we have abducted the thighs, or we have put the knees apart, then with one of your fingers, whether it's index or middle finger, you can actually feel the head of the femur which is actually lying out, and you could reduce it back. And actually the child is very small, so you can easily hold it in your hand. And when you do this, because if you see it over here, your hands are lying over at the knees, and when you have taken it out, it is already dislocated, you can easily use one of your fingers to actually push this head backward in. And this is they're doing it, that you abduct it, then you push it back, and if it comes in, this then means, and it will come in with a clunk. This means the autonomy is also positive. And when autonomy becomes positive with Barlow already positive, and there is a Galeazzi showing parallelism of the femur, therefore most likely the problem is at the hip joint, and the most common diagnosis is developmental dysplasia of hip. Now, how to go for Galeazzi test? Galeazzi test is very simple to perform, that you actually try to make both legs parallel. You may do the adduction of the hip joint, symmetrical flexion at the knee joint, and you make the ankle come close to it. Therefore, when the medial malleoli of the both ankles are touching each other, the knees of the both legs are actually touching each other. And in this position, when you look at from the front and you look at from the side, important is to look at from the side, because once you're looking from the side, you will exactly appreciate what is parallelism, and whether it's tibia or is it femur which is showing the parallelism. And remember, the bones which are parallel are actually the problematic, or that is where the pathology is. And if the femurs are parallel with already an autonomy and Barlow test positive, the most likely you are going in for a developmental dysplasia of hip joint. And then you will have certain other radiological indications to do, so that you can classify whether how much is the dysplasia, how much is actually the whether it's a sublux tape, or is it completely dislocated tape, or is it some other form of a pathology. But remember, if it would have been a teratological hip, both the Barlow as well as the autonomy would come up negative. Only Galeazzi will be positive. Therefore, the patient can still have that kind of a teratological dislocation of hip and having a DDH due to dysplastic acetabulum, but still the Barlow and autonomy may be negative even in early months. And usually any autonomy or Galeazzi test done about after 3 to 4 months of time is usually negative, because the muscles have developed and the contracture is now kind of a complete contracture which does not really move. Therefore, the head, if it is dislocated, will remain dislocated and will not come in, leading to negative autonomy despite having a dislocation. And if it's already out, you cannot actually make it come out again. Therefore, even the Barlow would be negative. Therefore, it is important to understand that Galeazzi, autonomy, Barlow, these are tests which are pathognomic of DDH, but they are done in a very subset of our population, which is usually there is no associated teratological hip, and usually the child is less than 3 to 4 months of age. Now coming to imaging, as I told you, the problem is that by 3 to 4 months of age, the femoral head starts to ossify. So if you get an X-ray pelvis AP view with both hip joints, you will not be able to appreciate anything on that, and you will not be able to appreciate any form of abnormality. Why? Because the femoral head is not ossified. You will not be able to appreciate whether it's subluxating or dislocating or where exactly it's going. Therefore, we go for the radiological investigation in form of an ultrasound. And how this ultrasound is actually done, that musculoskeletal radiologist is a specialized field, and they specialize in making the radiographical evaluation of the musculoskeletal disorders. And what they do is that the probe is actually placed lateral to the femoral head, and then this is actually the view which you see it over there. There is a calculation of alpha angle, and then there is calculation of beta angle. If you see it over here, this is basically the point of triradiate cartilage which is actually coming. These are the muscle, the glutei. There is actually called as the cartilaginous acetabulum, which is usually not visible on the X-ray, but on ultrasound you can appreciate it. Then this is the bony acetabulum. This is the triradiate cartilage point and the iliac crest. We calculate alpha angle as well as beta angle. Now, beta angle is calculated with this line bisecting in the cartilaginous angle. So, normal values of alpha and beta angles are such that Usually the alpha angle is more than 60 degrees and beta angle is normally less than 50 degrees in a normal hip. But always remember this mnemonic that a big beta is always bad. And I again repeat, big beta is always bad, because once the developmental dysplasia of the hip starts, this is the head of the femur, it will start to subluxate out. And if it starts to subluxate out, you will see there will be actually increase in the beta angle with decrease in the alpha angle. Therefore, in an abnormal hip, there is reduced alpha angle with increased beta angle. And as big beta is bad, therefore the patient may be having a dysplasia, dysplastic hip or acetabular dysplasia. Therefore, that is how you actually, in the first 3 to 4 months, the X-rays are not that useful. You will have to go for an ultrasound or musculoskeletal ultrasonography to actually calculate the alpha and beta angle so that you can appreciate whether there is associated developmental dysplasia of the hip or not. Now, once you have diagnosed it, whether the patient is having some form of a dysplasia or not, then comes the treatment, whether how to actually treat the DDH or developmental dysplasia of hip. The treatment depends on two things. First is actually the age of the patient, and whether the what sort of a pathology is there. If it's some sort of a teratological hip, whether whatever the age is, you will have to go for some form of reduction. But if it's a classical subluxated hip, or that's kind of a DDH, which actually subluxating out or coming out but not completely dislocated, then probably if it is less than 6 months of age, a child does comes to you, you send it to a musculoskeletal radiologist, and he or she comes back with a report that, okay, the alpha angles are low, but the beta angle is increasing, and this patient has a developmental dysplasia of hip. Then the first and foremost is always the brace in form of a Pavlik harness. That is, if child can be given Pavlik harness if he or she has age less than 6 months of age. So infants can only be given. Otherwise, you do not give Pavlik harness to the patients with either more than 6 months of age. If there is a teratological hip dislocation, then you cannot give Pavlik harness because that will not reduce it. Plus, if there is associated problems such as that you have given the Pavlik harness for 7 weeks, but there is actually no problem and no change in angles. The beta angle is still the same, the alpha angle is still small, and actually the dysplasia has not been contained. Therefore, you may have to go for the next step of the treatment, that is the close reduction and turn of fixation. Now, once the age is from 6 months to 18 months, now that is the kind of an age where the child has started to walk. And if the acetabulum is left as such, the problem is the child will try to walk, or as the child will start to weight bear, the muscles would develop, the ligaments would develop, and this would lead to increased dysplasia later on. Therefore, then from 6 months to 18 months, you may have to go for as close reduction internal fixation. Now, close reduction means that you do not open the hip joint and reduce the head back in, but rather that you do certain maneuvers peroperatively, and you check the reduction of the head on the fluoroscopy. If the reduction is adequate, then you simply fix the head with the 2 K wires and apply spica later on. And that is simple. The close reduction internal fixation with 2 K wires, provided the child has some form of a dysplasia, but the child age is between 6 months to 18 months. And once you have reduced it by a close reduction maneuver, the head is actually contained and inside the acetabulum. If it is not in the acetabulum, it's still subluxated or dislocated, then probably you will have to shift to the next form of treatment, that is open reduction internal fixation, in which you have to open the joint up, reduce the head back in, and all those factors which are actually hampering the head going back in. This could be hypertrophy ligamentum teres, this could be pulvinar, there could be a limbus there could be other problems as well, and plus dysplastic acetabulum as well. Therefore, you have to remove all those fibrofatty tissue inside of the acetabulum. You remove the acetabular ligament, which is actually contracted with inverted labrum is always there as well. And once you reduce it back, all the impediments to the head of coming back in is removed, and the head is reduced back in with the K-wires, and then you close the joint. This is form of an open reduction internal fixation. And usually if the child is more than 18 months of age till 3 years of age, then you have to go for this sort of a fixation straight away. You cannot, for example, if a child comes to you who happens to be a neglected DDH of 2 years of age, you will not go for some form of Pavlik harness, you will not go for some form of closed reduction internal fixation. You will have to go for the third line of management, that is the open reduction internal fixation with K-wires. And once you have to make it show that the head is reduced in. Why we need to have a reduced head? Because we need to make it sure that the head does not develop avascular necrosis, because avascular necrosis would be a tragedy for that child, because child having a problem of such magnitude so early on in the life would mean that would require multiple surgeries later on. And despite having multiple surgeries, patient may not be able to save the head, and may will have to go for some form of a total hip arthroplasty at the age of 25. So the problem is such that the first and foremost, our goals are such that you have to prevent head from going into some form of avascular necrosis. Now, preventing means whatever it is actually blood supply is, you have to put back into the acetabulum, so they let the blood supply do the rest. But if it is not in the position, therefore the vessels will be stretched, they may be torn, or they may not be having problems. The blood supply may not be going there into certain parts of the head, and eventually may become necrotic, and they may develop avascular necrosis. So our goal of any sort of a treatment in the case of DDH should be is to prevent head of going into dislocation and avascular necrosis. Then if unfortunately that child happens to be someone who has probably 3 to 4 years of age and still has been neglected, then probably we'll have to go for some form of bony procedures, because simple soft tissue procedures and K-wires are usually not enough. There are a plethora of osteotomies, but when we are talking about osteotomies, you have to remember whether we have to decide for certain type of osteotomy depending upon where the problem is. Usually the most commonly done is Salter osteotomy. And why? Because it can be done when the triradiate cartilage is open, and usually it closes by 8 to 10 years of age. Above all, the most commonly deficiency of the acetabulum is anterolateral, and Salter provides the best coverage for anterolateral coverage in case of Salter osteotomy. And then other options, we may have to combine acetabular osteotomy with femoral osteotomy as well. And sometimes because the head has gone up and out, therefore you may have to do some form of a varus T rotation along with the femoral shortening osteotomy. Sometimes you have to go for a hip osteotomy only, and if you see that you can contain the head, well and good. If you cannot contain, you may have to go for some form of associated femoral osteotomy as well. Other osteotomies is Pemberton. The important point is that Pemberton can also be done before the triradiate cartilage closes. Usually Salter is more than enough, but other options which can be done when whose hinge is actually on the pubic symphysis is Salter, there's Sutherland, there is steel, triple innominate. These are all can have the hinges over the superior pubic ramus, and usually are done before the closure of triradiate cartilage. The Pemberton osteotomy, the important point is Pemberton and Degas are actually the volume reducing osteotomies. What they do is that they reduce the volume of acetabulum. If the acetabulum is so dysplastic that it happens to be a patulous cup, for example, instead of having acetabulum like this in which the head is there, it's like this, as head can easily dislocate in and out because of so much dysplasia of the acetabulum. Therefore, we will have to go for some form of a pelvic osteotomy in form of a Pemberton osteotomy. And usually Degas is actually more of a sort of a reserved for cerebral palsy patient, because they have more common of the posterior superior deficiencies. Therefore, if we are going for a normal child who is not happen to be CP, but there is actually patulous cup, then probably Pemberton would be a better choice. As I told you, isolated acetabular osteotomies is sometimes not enough. We may have to go for associated femoral osteotomies as well, like proximal femoral varus derotation osteotomy along with the femoral shortening osteotomy, because otherwise if we bring the head down, this would result in because one leg is short, and eventually this may lead to neurovascular sort of injury because of too much pull on the muscles and nerves. Therefore we may have to reduce the femur so that equalize the limb length in form of femoral shortening osteotomy. Other is one of the options, once the triradiate cartilage closes, one of the reconstructive option of the acetabulum is the periacetabular Gans osteotomy. This is usually can be done in the case of if the child is of adolescent of age. Let's say child is of 13-14 years, triradiate cartilage is closed, but you don't want to, you can still salvage the head and you want to go for some form of reconstructive procedure, then the ideal option would be the periacetabular Gans osteotomy. Now, as I told you, this is how the close reduction is done, that we reduce it without giving any incision. We do not open the joint, and once we have reduced the head, we inject a dye into the joint by a simple percutaneous catheter, and we do the peroperative arthrography. And why we are doing the arthrography, if you can appreciate, this is whole of the capsule of the hip joint. You can very well imagine your dysplasia, actually where the head is coming out, it's also stretching the capsule. So if you reduce back in, and first to actually check for congruence, if the congruence is there, you inject the dye and you see how much is the medial dye pool. If the medial dye pool is more than 7 mm, this means your actually the reduction is not congruous and the head is somewhat still subluxed. Then probably you will have to go for some form of open addiction tunnel fixation. But if the dye pool is less than 7 mm, this means your reduction is congruous. You can simply accept the position, apply pass 2 K wires percutaneously without opening the joint, and postoperatively you can apply hip spica in the same position with almost 90 to 100 degree of flexion at the hip joint with 40-45 degree of abduction. In this position you can apply the spica and you can re-evaluate for the patient with the CT to check the concentric reduction is as you have achieved the concentric reduction or not. The next is Salter osteotomy. As I told you, when you are talking about osteotomies, usually the most common deficiency of acetabulum is anterolateral. Therefore, the anterolaterally the best is covered by a Salter osteotomy. If you see it over here, can you appreciate this is the right side? If you can appreciate, there is definite dysplastic acetabulum with the femoral head actually subluxating out as compared to this. Now, usually the best diagnosis is not on the AP view, but this is called as Fox view or false profile view. That actually tells us how much acetabular dysplasia is there on the anterolateral and how much anterolateral coverage is there. But Salter osteotomy can be done when the triradiate cartilage is open. If you see it over here, the triradiate cartilage is definitely open. We take a wedge out of the ilium, rotate it back so that we cover the head in such a way that head does not comes out, and we can graft this area and apply K-wire. This is a form of a Salter osteotomy to get maximum anterolateral coverage. Now coming to Pemberton osteotomy. Now if you see, as I told you, if you see, look at the cup, how much patulous it is. Because there is so much dysplasia of the acetabulum, the acetabulum index is very high, so you have to make it around 25 to 30 degree. To reduce that much acetabular index, you may have to go for some form of volume reducing osteotomy in form of a Pemberton osteotomy. The wedge has been taken in, osteotomy is done at the iliac level, and we have placed the bone graft over there, and so therefore this can be fixed with K-wires, and this is actually providing the roof for the head so that it does not dislocate out. And along with that, you have to go for some form of a varus derotation as well as femoral shortening osteotomy. Sometimes the problem is so much that isolated acetabular or pelvic osteotomy is not going to be enough, and you will have to do some form of femoral osteotomy as well. And usually the femoral osteotomy is always varus rotation with the femoral shortening osteotomy. Now coming to the periacetabular osteotomy or Gans osteotomy. Now if you see it over here, can you appreciate the triradiate cartilage has closed out? Although there is a lot of dysplasia. Now this is an x-ray of a skeletally mature child, probably an adolescent who happens to be 13-14 years of age. Because of the dysplasia, the triradiate cartilage is closed. Now the Salter, Pemberton, these are not the options, because there are only good options in case when the triradiate cartilage is open. Then we have to go for some form of a periacetabular Gans osteotomy, in which the whole periacetabular region is in osteotomy is done. It is actually fixed in such a way that the head does not goes out. Now coming to the femoral shortening osteotomy. Why is it done? Because when you see it over here, the problem is such that as the hip dislocates forward, it actually goes up because of the dysplasia. And when you bring it down, there's actually a lot of increase in the limb length, and more than 5 centimeter of increase would actually jeopardize the nerves, especially the sciatic nerve, which may get transacted and eventually leading to sciatic nerve injury. Therefore, when you have to bring it down to the native acetabulum, therefore you make a cut in the femoral stem or shaft so that you shorten the femur, therefore does not actually increase the limb length discrepancy. And later on, once you can once you have restored the actually dislocated hip, then you can later on address limb length discrepancy depending upon how much it is. Now coming to transient synovitis. If you remember our case study, that Robert, the child who came to us with the age of 5 years, he was having a problem with hip joint, and the problem was in the left hip joint, and there was a lot of limp. To understand the transient synovitis, you have to first understand a bit of anatomy of the hip joint, that this is the head of the femur. There's a ligamentum teres attached to it. There's increased blood flow actually coming. Majority of the blood flow in a child before the 4 years of age is coming through the ligamentum teres. And then there's on this edge you have attachment of the capsule. When the capsule is attached, inside the capsule you have a synovial membranes. The synovial membrane may actually hypertrophy and may increase, actually secrete a lot of synovial fluid, leading to a sort of a transient sort of a synovial effusion. This is called as transient synovitis of the hip joint. Usually etiology is multifactorial. Most commonly there's systemic infections such as viral or bacterial infection. Viral infection could be such as a common flu, or cold could also precipitate, especially in the young children of 4 or 5 years of age. As it was present in our case study, they may precipitate transient synovitis as well. They may have some form of allergic reaction to any antigen, which may be IgE mediated. And for example, if they may have taken some food from which they may be allergic to it, and then as a result, this may have resulted in, or there could be some form of a trauma. Usually, as it was in our case, the patient had a problem, a history of fall. There was mild form of trauma to the left hip joint, as well as later on he developed swelling, and there was limp. He was discomfort with walking, and there was issues with that as well. Now, when you have this sort of a scenario, you have to understand that you have to keep your differentials as well. And there are multiple other different diagnoses which does come to your mind, because first and foremost is always the age. If the pelvis is well squared, or there is no pelvic obliquity, and at 5 years, less likely to have a DDH, because by the time the DDH would have been diagnosed and treated for most of the time. There is very rare possibility that DDH was left neglected until 5 years of age. Then other differentials which does comes to our mind are like infections, osteomyelitis, LCPD, scaphy even. But what are the actually symptoms which usually the patient presents in the case of a transient synovitis? As it was in our case, the most common was painful limb. The patient complains that when he or she walks or stands, there's a problem of the hip joint. Next is there may be a radiating pain towards the thigh or towards the groin area as well. May be associated with the knee pain. Usually if a child of let's say 12 or 13 years of age and complaining of actually knee pain, you must assess their hip because there may be associated scaphy, and that is the slipped capital femoral epiphysis, which may be having a problem of, as a result there's a radiating pain to knee. The problem is not in the knee, but the problem is actually in the hip joint. And then maybe radiating pain towards the buttock side as well. So the pain which may be associated with the swelling of the joint and decreased movement, which was in our case study as well, that the patient was having limp. When we examined the child was having a problem with the flexion and extension, there was pain on the passive movements as well. Now once you do the physical exam, you see certain limitations of weight bearing. The child will be unable to bear weight and would be unable to walk without discomfort. There will be limited movement. Now limited movement means either the patient will come and tell you that he or she is not doing these things, or not actually getting out of the bed from last 2-3 days, or let's say the history would be short, it will be less than a week history, or when you do the examination there will be actually decreased range of motion. Others may be associated with some form of muscle spasm, because keeping the limb in certain posture for over prolonged time, the certain limb muscles may go into some form of a spasm as well, and may be associated with low-grade fever. Although fever actually points out to some other form causes as well, but when associated with low-grade fever, one of the differentials could be transient synovitis. Now, what the testing is, whenever you have a fever, you must rule out infection. And when we go for blood test, which may include complete blood count, there may be absolutely normal or mild increase in the TLC, but usually it's normal. ESR usually is normal. C-reactive protein is usually normal, and that is actually where this, if in case would have been some form of infection or osteomyelitis, you would see a rise in the TLC or lymphocytes, you would see a rise in the ESR, you would see a rise in the CRP. But in case of transient synovitis, usually they are within the normal limits. Therefore, we may have to go for a normal laboratory test such as blood, CP, ESR, CRP may not be enough. We may have to go for some form of special test, which include actually ultrasonography, which would actually tell us whether the hip joint is swollen and is there any fluid or not, and then we can aspirate that synovial fluid, test for culture sensitivity, and then we can go for synovial fluid routine examination as well. And if there are no actually polymorphonucleosides, there are no actually organisms on that synovial fluid, most likely the aspiration is negative, and then that means there is less likely to be an infection. Other formation is MRI. There are definitely changes on MRI, and usually the classical scenario for transient synovitis is a child of let's say 3, 4 or 5 years of age, as less than 7 days of history. Problem is with the limp and decreased range of motion, with almost all labs are within normal limits. Aspiration, culture sensitivity normal, but when you get an MRI, you say signal changes on the MRI in the bone. That is where the diagnosis point starts to point towards the transient synovitis of the hip joint, especially in the pediatric population. Now coming to the differential diagnosis, which is they are all as important as the actual diagnosis, because sometimes there may be a low-grade virulent organism which may be there may be sudden infection. So you have to be absolutely clear that this is not some form of a septic arthritis, because septic arthritis, which eventually may become full-blown septic arthritis, and then you will eventually know that this patient has septic arthritis. But by that time, there may be some sort of a cartilage damage, and later on the patient will have developed early arthritis, and which may require some form of a replacement surgery. Therefore, septic arthritis is something which we must keep in mind, especially when the hip joint of a child of a young age comes with a swelling around the hip joint and decreased range of motion. Other is septic arthritis. You have a certain diagnostic criteria which actually points towards the septic arthritis, and if all these criteria is actually negative, then the septic arthritis is to be less likely. There are 4 criteria. First and foremost is always fever greater than 38.5. High grade fever is very pathognomic that the patient is having some form of septic arthritis. Usually with the transient synovitis hip, there is either no fever or there is very low grade fever. Then it could be WBC count on the blood CP could be more than 12,000 per liter. Then ESR more than 40, CRP more than 2, and inability to weight bearing. Now CRP is usually not part of the actual criteria. This is called as cautious criteria, which can contain 4 things only, which was fever, WBC, ESR, and inability to weight bear. If the child is having a problem, like a child is having high grade fever more than 38.5, TLC more than with 12,000 with primarily neutrophils raised, ESR more than 40, and inability to bear weight, there is almost 99% chance that the patient is having a septic arthritis. And even if the 3 are positive, for example, child is unable to weight bear, there is ESR positive, and this WBCs are raised, patient may not have a fever. Patient may be on antipyretics and may be taking some sort of over-the-counter medicines. And then there's still 93% chance that this patient is having a septic arthritis. Other differentials which may be coming, for example, if there's low-grade fever and almost a prolonged sort of history in which there's only mild sort of symptoms, probably is due to osteomyelitis with the proximal femur as well. But usually in proximal femur osteomyelitis, there will be some changes on the blood work, and ESR, CRP, TLC would still be high. They will not be absolutely normal. Other is LCPD or leg calf Perthes disease. Now this is a very common disease of usually in boys, and as Robert was a 5-year-old boy, this is kind of age bracket from 4 to 8 years. This is usually the most commonly LCPD presents with between the age of 4 to 8 years, and in that case you have to rule out the infections, osteomyelitis, septic arthritis, LCPD, as well as another disease called as metaphyseal epiphyseal dysplasia, because sometimes they may also present with swelling, a painful hip joint, and there may be underlying some form of a dysplasias of the pediatric population, such as multiple epiphyseal dysplasia may present and may mimic transient synovitis as well. Now, how to treat the transient synovitis? The first and foremost is that you have to rule out this not an infection, this not osteomyelitis, another cause. Then is the bed rest, that you ask the patient to continue taking rest and put the limb in a posture which is actually more comfortable for the patient. Then is administration of non-steroidal anti-inflammatory drug. Now, a child may be able to take the medicine. If child is young or not able to take medicine, for example, in our case, it was 5 years of age child, you can go for some form of a non-steroidal anti-inflammatory syrups as well. Then is crutches, to make the patient comfortable and pain-free, and if patient wants to ambulate, can ambulate with the crutches so that it does not put a lot of weight on that joint as well. The other treatment is usually the first and foremost is there's no surgery for transient synovitis. It usually resolves with symptomatic and conservative treatment, and it actually most commonly resolves. But then again, the most problematic problem is usually it's the recurrence. There is a lot of complications associated with the transient synovitis, and most commonly it is always the recurrence. There could be several other sequelae, which could be, for example, the head may become deformed and enlarged mushroom-like, eventually becoming coxa magna, with some form of a dysplasia as well, which may require THR at a very early age in form of a total hip arthroplasty. Or when we are treating, for example, transient synovitis, or for example, this may lead to it may be associated with certain other fractures as well, and once there is treated with certain, for example, recon nail for the femoral nail, this may lead to over lengthening of the affected limb as well. But usually the transient synovitis, there is no surgical treatment. Most commonly it resolves by simply conservative and symptomatic treatment. In this lecture, we have briefly gone through the two very important pediatric hip conditions. One of them is developmental dysplasia of hip, and other is the transient synovitis of the hip joint. The first and foremost is when a child is born, if there is some problem with asymmetrical skin fold of the thigh, one must go for Barlow, Ortolani, and Galeazzi test to rule out DDH. And if we have a suspicion, if we have a high index of suspicion, we can go for ultrasonography to confirm the alpha and beta angle, and later on we can go for X-rays as well once the child has attained the age of 3 to 4 months. The treatment to start with is always Pavlik harness in case of DDH. Then we move on from closed reduction tunnel fixation, then to open reduction tunnel fixation, and eventually at the 5-6 years of age we have to go for some form of osteotomy. The most commonly osteotomy is done is Salter osteotomy, along with the femoral shortening and varus rotation osteotomy. Then we briefly discussed the transient synovitis of hip, how it mimics usually other diseases such as infection, septic arthritis, LCPD, SCAFE, or even the MED as well, or multiple epiphyseal dysplasia. Usually this child is around 4 or 5 years of age. There is short history of limp, pain, swelling, but when you get the blood work, that's usually within the normal limit. The treatment of transient synovitis of the hip is usually symptomatic and conservative treatment, and there is no surgical treatment needed for the relief of the transient synovitis of the hip. Thank you very much. Keep watching sqadia.com.